genocide and slavery. To childhood experiences of abuse and neglect, and faults, and even social determinants of health can be experienced as traumatic. So homelessness, food insecurity, economic instability. Another form of traumatic stress is secondary traumatic stress, which is a set of symptoms nearly identical to PTSD that are the consequence of caring for a person who has been traumatized. For instance, a medical provider who takes care of someone who has just been the victim of a violent crime and then goes on to experience intrusive thoughts, hyperarousal, hypervigilance. And those intrusive thoughts can even include vivid images of their imagination of what happened to that person. We'll talk more about how to prevent, strategies for preventing or taking care of secondary traumatic stress near the end.
So that's a brief introduction about what trauma could be, a very broad definition of all kinds of things that could be experienced as traumatic, from the individual all the way up to the societal levels. And trauma is a very heavy topic. It carries a lot of weight, and it's very difficult to be a healthcare professional oftentimes because of what we're witness to: pain and suffering. And so for me, what's helpful is thinking about, what can I do about this? How can I act? How can I respond? What is in my control to combat the effects of trauma in my patients and coworkers and society at large? And what I have discovered as a very helpful tool is this field called trauma-informed care. So I'd like to introduce a little bit about what that is. So next slide, Leah, thank you. Trauma-informed care was developed 20 years ago or so. It's an organizational framework for how to support people who've experienced something traumatic. And we call it a universal precaution, almost like washing your hands before you touch the patient. We apply these principles universally as a means of building resilience for ourselves and for our patients. Very importantly, it emphasizes safety first: physical safety, psychological safety, and emotional safety, and it aims to empower the trauma survivor. Notice that I'm very intentionally using the word survivor rather than trauma victim. For me, what I love the most about this, and what's a very important takeaway, is that trauma-informed care aims to foster healing through safe and collaborative relationships. Healing happens in connection with other people, which is beautiful because it means that every interaction you have with a patient is a blessed opportunity to reverse the negative impact of trauma. You all have the capacity to communicate care, to offer love and healing through a patient's recovery. Your, let's say, 15-minute encounter with a patient can be super transformative and really positive and memorable in that patient's life as they recover from their trauma. Next slide. These are SAMHSA's 4 R's of any trauma-informed organization, trauma-informed program, trauma-informed policy. We aim to first realize the widespread impact of trauma. We then aim to recognize the signs and symptoms in ourselves and in our patients and staff. We aim to respond by putting trauma-informed measures into practice, both now and in the long term. And finally, and importantly, especially as we discuss the physical exam later, we aim to resist re-traumatization. We try to not we try to reduce the risk of patients feeling activated and triggered in the healthcare environment, remembering something bad that happened to them in the past and feeling uncomfortable now in the present. So you can see how there's safety throughout the structure of a trauma-informed approach. And next, we'll show you again from SAMHSA the 6 principles of trauma-informed care. And I'd like you to keep these principles in mind as we proceed through the rest of the talk, because they can be applied to everything you do. Trauma-informed principles can be applied to the physical exam, to communication with patients, to the way you do the interior design of your exam rooms and hospitals. It has broad applications. So number 1 is safety above all things. Number 2 is trustworthiness and transparency. We aim to be clear and transparent throughout the healthcare system. 3 is peer support. That's about all of us connecting with one another as survivors, sharing our pain, sharing our healing, helping one another. 4 is collaboration and mutuality. You are partnering with patients. There is a leveling of the power dynamic, power differential that exists sometimes between patient and clinician. 5 is empowerment, voice, and choice. You want to hear the patient's preferences. You want to put them first. The treatment plan will be guided by them and their choices. And 6 is attending to cultural, historical, and gender issues, which is a very broad, very important, very difficult topic to address. And we welcome you all to ask questions or provide suggestions for any one of these principles as we proceed through our talk. We will be allowing for adequate time for discussion at the end. I think someone is unmuted. Thank you so much. So now we're going to just briefly mention, what does trauma look like? How can you recognize it when you see it? What are the manifestations of trauma in your patients? These are the things that I commonly see. I'm what's called in the United States a primary care physician. I practice general internal medicine, so I'm a regular doctor for regular things. And one thing that I see is avoidance of routine primary care. People want to avoid a pelvic exam. They're not going to schedule their colonoscopy. They're going to put off going to their dental appointment, even though they have pain, because the mouth can be a very sensitive area. Number 2, they may not show up to their appointments. They may cancel their appointments where they think, oh, I'm going to get a rectal exam. I don't want to come to see my doctor. They can have vague general symptoms that persist for many years. For example, chronic headache disorder, chronic pelvic pain, where all of the testing has been normal and nobody knows what the cause is. They may avoid disclosing symptoms to you that may prompt an invasive exam or test. For example, they may not tell you that they've been having rectal bleeding. They could appear nervous or distracted during the appointment. They may not adhere to the treatment plan that you recommend, or you could see that someone has very severe chronic disease in multiple organs. For example, somebody in their 40s who looks like they're in their 70s and has had many medical procedures and surgeries, etc. I'll leave this to Leah now to chat about the way that PTSD can manifest, post-traumatic stress disorder.
Chart is a helpful tool for diagnosing post-traumatic stress disorder. So it depicts the diagnostic criteria according to the DSM. So at least 6 months after, this is about at least 6 months after the event, is when you start talking about PTSD. Prior to that, we're talking about acute stress reactions, which are really pretty natural responses to catastrophe. Whereas once you get past 6 months, we're starting to think about, is this persisting longer than ordinary? And might treatment be appropriate? So at least 6 months after the event, we'd be seeing intrusion or re-experiencing symptoms associated with the traumatic event. such as nightmares or intrusive memories. Those intrusive memories can even feel as though they are happening in the present with very real feeling, visual, auditory, and physical experiences. We'd be seeing some sort of avoidance of trauma-related stimuli. So anything that reminds the person of the traumatic event. Some of those triggering stimuli may not actually make any sense to the patient. They may not even be able to identify them because sometimes that kind of information can be encoded in the body and not available to the conscious mind. We'd be seeing negative alterations in thoughts and mood associated with the traumatic event. So you might be seeing some depression or high anxiety. You might see isolating, social withdrawal, loss of interest in things people once enjoyed. And finally, you'll see changes in arousal. So an exaggerated startle response sometimes, hypervigilance, difficulty concentrating, irritability or reckless behavior, and oftentimes sleep disturbance as well. And we want to see these symptoms persisting for about a month.
One thing that comes to mind for me as I'm looking at this table in the third column is negative alterations in mood, loss of interest, and withdrawal. This can often show up if we're talking about mental illness as depression. And so it's important to note that not all people who are looking down and feeling down are just depressed, for no reason, or should be treated with just a medication and that will solve the answer. So through curiosity and your generous time, it's important to further question how or why this might be happening. And so we're going to talk soon about screening for trauma too.
Really glad you said that because in primary care where I work part-time, about half of the depression referrals I get end up being something more in the trauma realm once we do closer evaluation. So that is a nice segue into trauma screening. So trauma screening or traumatic stress screening, both, are an essential part of trauma-informed care, not only because we need this, of course, in order to identify our patients who are suffering from PTSD, but because the act of assessing traumatic stress can actually be a profound intervention in and of itself. First, I'd say simply by asking if someone has experienced a traumatic event and then taking the time to ask about traumatic stress, we're validating the lasting, profound, but often invisible impacts of violence. It goes without saying that time is precious in a medical visit and that you choose to talk about things because they're important to a patient's health. So what message does it send when you take that precious time and you spend some of it talking about how the patient is doing in light of something terrible that happened? It's really powerful for the patient. These are a few screeners that we have access to, and I'm not sure about what languages. I know that they, in terms of the main languages that our patients here at Cambridge Health Alliance speak, we have access to many of these screeners, but I'm not sure for like locally what types of trauma screeners are validated. It's something that would be good to look into. We're going to dive in and take a closer look at one of these, which is the PC-PTSD-5. It's a 5-item screener, or sort of a 6-item. It was developed in VA primary care clinics. And the first thing that happens is patients are asked if they've ever experienced a traumatic event. And several examples are provided. This could be spoken to the patient, or it could be handed to the patient for them to read, depending on their situation and what's best for them. And it says this, it says, sometimes things happen to people that are unusually or especially frightening, horrible, or traumatic. For example, a serious accident or fire, physical or sexual assault or abuse, earthquake or flood, war, seeing someone killed or seriously injured, having a loved one die through homicide or suicide? Have you experienced this kind of event? It's not asking them to, it's not making them share which event. It's not asking them to share the details of the event. It's just asking, has something like this happened to you? And if they say no, you're done for that visit. If they say yes, you move on to 5 questions. And they are all yes or no questions about PTSD symptoms experienced over the past month. This is another example of how screening can be a profound intervention. Within these questions contains vital information, symptoms. The fact that these experiences are symptoms offers context to something that may have been experienced as truly maddening in isolation. Many traumatized people believe they are going crazy. They don't know what they have. They don't know that they have an invisible injury that is no less real than a broken arm. And when they see that there is an official term, PTSD, with official symptoms that can explain what they've been experiencing, it can sometimes lift just a little bit of the shame that they've been carrying. And shame is really the biggest antidote to healing.
Shame reduction.
Shame reduction. Yeah. Shame really does thrive in isolation. So we have to talk about this stuff out loud and with as much compassion and confidence as possible. Just tough, take some practice. So the psychometric properties of this scale have been validated in a military sample, and it uses a cutoff of 3 items endorsed. So if somebody says yes to 3 or more, we consider that very likely to meet criteria for PTSD. And it was accurate in correctly diagnosing PTSD 95% of the time when compared to a clinical interview. Now, another way that you could screen for trauma is simply by asking a question like this and not necessarily using a standardized measure. So this is one of Dr. Alicio's ways of screening for trauma by just asking, many of us have experienced something difficult, whether in childhood or later as an adult, that has had lasting impact on our physical or mental well-being. Do you think that's relevant to you? And if they say yes, following up with, is that something you'd like to speak more about today? I love this question because it's really respecting the patient's autonomy. It's saying, this matters to me, I'm bringing it up, but it's up to you whether we go any further here. So it's respecting their choice, which is a key part of trauma-informed care. So this next tool is called the PCL5. It's a PTSD checklist for the DSM-5 criteria of PTSD. It has 20 items. And I'm really only presenting this because when I've given these trainings to primary care clinics in the past, I've been told that people really want a way to monitor symptoms in response to their own interventions, especially when their patients don't have access to mental health care. So this checklist is a way to do that. You can give this to the patient and get a severity score of their symptoms. And if there is a change, a 5 to 10 point change in their score, it's considered a reliable change. So you might, begin working with them on something, offer some intervention related to their trauma, and then check back in with the scale again in the future and see if anything has shifted. Oh, you are still on mute.
We've spoken a little bit about trauma and the principles of providing care that is trauma informed. We shared about how to screen for trauma and how to potentially monitor the effect of treatment by checking symptoms of PTSD over time. So When you do screen for trauma and people tell you the horrible things that they have experienced, sometimes we feel as healthcare professionals stuck, like, oh my goodness, that is a lot of important, very challenging information. What do I do now, right here in this second? So I'd like to share with you some possible phrases that we might use to help us know what to do next. The first here in green on the upper left is just sitting in silence. Sometimes just being there is exactly what you're supposed to do for that patient. Sitting there silently as they cry, as they vent, as they share, just being there. Provide space for their emotions. You may be the only person in their lives who is there just sitting and listening and allowing them to say, I am scared. I feel helpless. I just want to cry. And that in itself is an act of love and great care. You can thank them for sharing something immensely personal and difficult, because it takes a lot of courage to share tough stuff, especially, as Leah mentioned, because this is wrapped in a lot of shame. There in yellow, use your nonverbal skills to communicate care empathically. You want to make sure that your body posture is open and turned toward them. You're not closed off. You're going to provide appropriate eye contact. You're not going to be distracted doing other work. Make sure that you're speaking at an appropriate volume, no loud noises, etc. Here in the center of the screen in blue, explore their resilience. You can say, my goodness, what has kept you so strong through all of this? I wonder, what do you think is responsible for your getting up every day and still showing up for your family? How have you been able to do it? What is right with you rather than what is wrong with you? In purple, we write here, be an advocate. You have a powerful position in your role as a healthcare professional, whether it's a doctor or psychologist, social worker, or any other role that you play. You are able to advocate within healthcare to be an agent for change, structural systemic change. You can provide verbal expressions of empathy, and I'll give you an example of one way to do that well. And you can partner with the patient for next steps. It's not up to us as the doctor to say, here's what you need to do next. The patient knows their life best. They know their symptoms best. They know their circumstances and their needs best. And you can ask them, what do you think the next step should be? And if they say, I really don't know, that's an opportunity for brainstorming together. But the next steps should really be patient-led, patient-preferred. So I'd like to show you one tool here that I really love as an opportunity to make verbal expressions of empathy. This here is the NURSE acronym you see on the left, NURSE, and it stands for naming the emotion the patient's experiencing, express understanding, offer a statement of respect, tell them you support them, and then if there's time and if you're interested, you can explore it further. So I'll give you an example of what I can say in a string of sentences that may express care. I can say, wow, this has been a really frustrating time for you. I can understand how you'd be feeling that way. It sounds like you're just doing the best you can. My only role is to support you. And then you pause. I remember the first time I used this tool, I was covering a colleague. I saw a patient who was practically vibrating. He was so angry, so in pain. And when I said this, his shoulders dropped and he wept. And he said, nobody has ever spoken to me like that. Will you be my doctor? And time again, this works like magic. Why? people want to be heard, they want to be seen, they want to be valued. And so in the space of, I don't know, 15 seconds, you can really make a transformative impact. Next slides. Let's see what's next. Sometimes we're at a loss for words. What can I say? Can you show me some examples? And so one thing is, thank you for sharing that with me. There should be an opportunity of thanking the patient for trusting you with the honor of that private information. It's a huge honor that we have as clinicians to be witness to these private things. You can say your feelings and reactions make total sense. Of course, given what happened to you, this is very normal. We're all human. You can say, I'm amazed that in spite of all you've gone through, you're still managing to go to work, provide for your family, come to this appointment, get dressed in the morning, take a shower. What has kept you going? And you can say sometimes talking about these things can bring up some difficult feelings. It can help to come up with a support plan. Can you think of any supports you can put in place for yourself today and tomorrow? Would it be helpful to speak to your wife about this? Would it be helpful to reconnect with an old friend? Would it be helpful to cook with your grandmother? Would it be helpful to sing a song or go to church or pray? And one of the things that I struggle with as an internist, I am not a trauma therapist. I have no training in psychology. I have no training in psychiatry. There's a balancing act between being open to receiving what the patient has to say and wanting to put some boundaries on it. How can I contain this so that I am not damaged by their sharing? Because you need to preserve yourself going from patient to patient to patient. There's a lot that you can get weighed down by from the stuff that you see. It's almost like you're carrying an invisible backpack with all of these rocks. And sometimes what you see and hear about is just putting more and more rocks in that backpack. So, one thing that I struggle with is wanting to hear what's going on with the patient, but also put some limits. And so perhaps Leah can share with us how she does some containment.
Yeah, this is something that comes up a lot because we're aiming, when we're doing a trauma assessment, we're aiming to access some of the information about what happened to the person without completely overwhelming them and ourselves. So if someone is becoming unresponsive or inconsolable during a discussion about their trauma, it's likely time to compassionately observe what's happening and do some grounding, what we call grounding. So I'm going to offer some examples of how to do that, including how to interrupt, which doesn't feel good, a conversation and intervene when this is happening. So this is an example of what I might say as the provider. I might say sometimes when we talk about traumatic events, it can bring up a lot of overwhelming feelings, or the opposite can happen and we start to feel numb or disconnected. Sometimes people even shift back and forth between those two experiences. What are you noticing right now? So what I'm doing is I'm actually teaching them so many skills by saying that, because I'm telling them a little bit about traumatic stress, which is that going back and forth experience between numbing and flooding. But I'm also helping them shift towards observing what's happening now. So it's mindfulness, and it's also getting to know themselves and building some interoceptive awareness. This is actually emotion regulation skill building in action. So the patient might say, I'm feeling kind of panicky, or I don't feel anything. Like they might look very disconnected and numb. And then I might say, I have a tool that can help when you're feeling that way. And I'd like to teach it to you now so that you can use it anytime you need to when this happens again, because it's probably happening to them many times a day. These tools, which I'll share a couple of in a moment, are pretty quick and don't take very long to teach, which is nice. And they go a long way. I want to show you or introduce you, if you haven't been introduced yet, to the window of arousal tolerance, which is a key tool in trauma treatment. So what we have here is a chart showing a range of arousal from hypo to hyperarousal, with this zone in the middle. Some people call it the zone of resilience. It's the space in which we can experience some stress and still feel like we have our 2 feet on the ground and like we can think. Hyperarousal is when we are experiencing a high sense of threat. We might feel the need to run or just have a lot of stress hormones pumping through our system. We might feel really tense, that fight or flight experience. In hypoarousal, it's sort of the opposite. It's this experience of feeling numb or empty, dissociated, disconnected, immobile, frozen. And then, like I said, in the middle, I sort of described already, sort of the feeling of feeling actually quite grounded despite having a certain amount of stress.
And Leah, could you share how patients may appear or look or behave in these windows?
Yeah, so somebody who is hyper aroused, their leg might be shaking up and down. They might be fidgety. They might be having a hard time sitting still. They might even be pacing. Their eyes might be darting around the room. One thing about hyperarousal is some people will appear perfectly still and actually be experiencing quite a lot of distress internally. So you can't always tell just by their movements. They might be speaking more quickly. They might be more reactive. Somebody who's hypoaroused, their affect might be a little off while sharing information. Like you might think that they would be more upset based on the things they're sharing, but it's more of a blankness, maybe a staring off to the side, not looking at you. That's how I might, some common presentations, but you could really see quite a range. The average patient is going to be on the upper end of the window of tolerance. Like even if it's in the zone of resilience, they're still going to be on the upper end of that during a medical visit, because going to a medical visit is often stressful for people. For patients with histories of childhood abuse and neglect, or who have experienced interpersonal violence, going to a medical visit is often so distressing that they become hyper and hypo-aroused, often vacillating between the two during a visit. And as a medical provider, we are caretakers. And many people have been harmed by the very people who were supposed to protect them. When you add in other power dynamics that are rooted in structures of oppression, a doctor's visit can become a perfect scenario for traumatic re-experiencing without you even doing a thing. You don't even have to open your mouth and people can feel quite re-traumatized. Luckily, there are lots of ways we can actually support moving patients and ourselves, because we can also get dysregulated when we're with a patient who's dysregulated, into the window of tolerance. Sometimes it's possible to have things shift for the better in a single visit, like in a couple minutes. And other times it can take many visits over a long period of time with intentional work toward creating that safety to make it possible for a patient to eventually be able to come to a visit and feel safe. Two of my go-to quick grounding techniques. One is just statements about the orienting statement. So where am I right now? What day is it? My favorite is how old am I? Because a patient who's being re-traumatized to childhood trauma will often feel almost like a child again, like really young and unsafe and without agency. So I will introduce these statements. I'll say, this might sound really weird, that what I'm going to ask you to do right now, but it's a skill called a grounding skill that is really weirdly, magically effective in helping with traumatic stress symptoms. So just humor me, if you will, and let's try this. I'll do it first. Where am I right now? I'm at the primary care clinic in Cambridge. Today is Thursday, April 14th. You know, it takes a little work for me to like think. I'm getting my brain back online a little bit. What is the month today? What is the year? And how old am I? How old am I? 34 years old. Then the other skill, which I actually use more often, is just naming 3 things that you see, smell, hear, and feel physically, and saying them out loud. And people, when I introduce this, often are like, what is this person doing? Like they really feel a little bit baffled by my behavior, asking them to do this. But by the end of the exercise, almost everybody will report feeling a change in their physiological state. So I name out loud with as much specificity as I can muster 3 things I see around me. Smell is a tough one, but we try to get a couple. And then hear and feel physically. Like I feel my feet on the ground. I feel this chair. I feel my hair on my neck, right? And maybe taking some deep breaths while we do this. So I'm going to introduce you just to the very basic, like broad strokes overview of the gold standard of trauma treatment in the US, I would argue, which is this triphasic model of treatment that Judith Herman came up with. She has that book I mentioned earlier, Trauma and Recovery, which I recommend. Any provider can support this first stage of treatment. This is the focus. Stage 1 treatment, establishing safety and stability. This is all about personal safety, self-care, emotional regulation, and shame reduction. Another key part of stage 1 treatment is psychoeducation, which you're doing by introducing traumatic stress, by screening for it and talking about symptoms and talking about grounding. That's all stage 1 trauma treatment. These other stages, stage 2 and 3, that are about kind of exposure work and processing the details of the events, those are things we don't recommend our medical providers do, because they do take a bit of like training. So unless you're going to go and get some pretty extensive training in that stuff, I would stick to this stage 1 situation, which is in and of itself very healing. So we talked about, like I said, we talked about psychoed through screening, but I also like to have patient-friendly handouts and information that I can offer somebody about the fight or flight response, about the relaxation response, and about the window of tolerance. So these are just 2 pages from one of my favorite little booklets for, it's actually 4 patients that I have on hand all the time. It's called, this one's called Calm Ground. But there's lots of patient-facing info out there that can be really useful, especially if you pull out stuff that's really good and talk to them about it and hand it to them so they can keep reflecting on it on their own a little bit. All right, I'll talk to you about the post-traumatic stress response cycle. So one thing we can do is teach patients to become aware of this cycle and interrupt it. This is the cycle of getting triggered. So having some reminder of the trauma, experiencing a rush of adrenaline or cortisol in the body. People often feel like their head hurts. They feel their heart pounding. They feel shortness of breath. They can feel actually all sorts of physiological sensations. It's pretty wild. Shoulders and neck can become tight. And then that pain and that uncomfortable, all that discomfort can actually continue the cycle because it's distressing. And round we go. But there are ways, like I said, of doing something called completing the stress response cycle, which is a way of exiting this cycle, which I'm going to show you some of those strategies. So here are some examples: mindful breathing, any kind of physical activity, just exerting oneself for even a minute, some kind of creative expression, crying, laughing, physical affection, some kind of positive social connection. Shaking is something that can be quite helpful for completing the stress response cycle. So I want to explain briefly why this works. When we face an actual threat, so not a trauma trigger, but an actual threat in real time, the stress hormones that pump through our body are there for a purpose. They help us to run or fight or stay perfectly still in some cases. Say we flee from that danger and we run towards home. We're out somewhere, there's a danger, and we start running towards home. We've just used that adrenaline for something. We've expressed it. Then we get home, we find our loved ones, we share what happened, they embrace us, maybe we cry, maybe we shake. I don't know if you've ever been through a really dangerous situation and then afterwards found yourself shaking and you can't stop. That's the body doing what it needs to do to heal, to recover. And really all of those experiences help with that, from the social connection to the embrace, to the movement, to the crying. One thing that can profoundly interrupt this natural healing that happens when we let our bodies do what they're supposed to do is when there's a particular trauma that is stigmatized, such that people are too ashamed to talk about it. Then they suffer alone and are much less likely to recover. So lastly, I just wanted to share with you some of the interventions that I teach my fellow therapists to use in primary care. These are all considered stage 1 trauma treatment interventions that can help people move towards safety and stability. Like we actually discussed many of these, but I just wanted to lay them all out. So we've got psychoed about trauma. We've got those grounding skills, and normalization and shame reduction happens. It's like baked in to the screening and the psychoed, and maybe just, a sentence of compassion. If somebody's dealing with current day threats to their safety, it's essential to talk about how to build safety and safety plan. Teaching problem solving skills is behavioral activation. I'm referring to helping people identify the things that they once did that brought them joy and make a plan to do those things. Any kind of empowerment and assertiveness training, which is often around communication, conflict management, and instilling hope every single time you meet with somebody, instilling hope. That can be done just in the interaction. You don't have to even do anything sometimes, but I'd say one way to instill hope is to let people know that what's happening to them is an injury. It's not a chronic, it doesn't have to be a chronic illness. It's an injury that can be healed, just like many other things they come in with. And we're gonna get there. Just saying something like that can go a long way. On to you. Oh, I'm gonna stop presenting. Okay.
I think I'm sharing screen already. So this next section, we're switching gears a little bit to talk about a trauma-informed physical exam, but I do want to just give everybody a little break, just 30 seconds. Empty the mind, stretch, deep breath in and out. I'll pause for another 20 seconds or so, just a little break. Okay, that feels good to me. Thank you all for the pause. So My story is that when I started my clinical practice, I realized that there were things I was doing on the physical exam that were making my patients visibly uncomfortable. I remember swinging my stethoscope off my neck and the patient jumped. I remember approaching them for the thyroid exam and they shook back like this. So I started adjusting my speech and my behaviors with the hope to set them at ease, make them more comfortable. And one day a medical student asked me to teach her more about my trauma-informed approach. I had never heard of that before, but I thought it was extremely interesting. I read more about trauma-informed care and I developed a formal framework for a trauma-informed physical exam. We were able to publish it. If you look online, just to search for trauma-informed physical exam. The curriculum is available, and I've had the honor of being able to teach this at medical schools across the United States. So I'm going to share an abbreviated framework for what this is. We'll talk about what to do before the exam, what to do during the exam, and how to close after the exam. I'll share that this is very much a guide. These are suggestions. They're not required. They are not meant to be performed in a certain order. I have not tested this. These are just thoughts that I would like for you to experiment with. You can ask questions about it. Maybe they will work in your own environment and culture and country. Maybe they won't, but this is stuff that I am trying to practice with my patients. So before the exam, we make sure that our nonverbal communication is appropriate. What does that mean? We speak clearly and slowly at an appropriate volume. We appear engaged and pleasant and calm as much as we can. Appropriate eye contact. We stand or sit at eye level with the patient rather than them sitting down low and you standing up above them. Avoid sudden movements, keep hands out of pockets so they know what you're carrying or not carrying. Pay attention to what the patient's doing. Are they looking tense? Are they breathing quickly? Are they crying? Are they distracted? And if so, you can pause and just ask about it. Ask, I notice you look very tense. Can you tell me more about that? We set an agenda for the exam, and I'm going to ask Leah to read what's in these little bubbles. This is sample phrasing for something you might say.
I'd like to transition to the physical exam. We will be doing a pulmonary exam today, so I will be listening to the lungs.
This way, the patient knows what to expect. Next, we make it standard practice.
This is something that I do with all patients who come in with symptoms of a cold.
It's not being done for no reason or just for fun. You identify if the patient has any concerns before you do the exam.
Do you have questions or concerns before we begin?
Ask about their comfort.
Is there anything I can do to make you more comfortable?
And finally, offer a chaperone.
Like anyone else to be present for the exam.
And this is something that I find very relevant in the United States. Ubitu looks like you're, yeah, thank you so much for reading yourself. So in the United States, many institutions like hospitals require a medical chaperone for women who are getting a pelvic exam or breast exam. All of my patients happen to be men, and they are the ones who taught me about the impact of sexual violence. So we need to think more broadly about medical chaperones and for whom they're appropriate. During the exam, we attend to appropriate draping of patients. Leah.
In order for me to do an accurate exam of the lungs, I'll need to listen with the stethoscope directly on the skin.
And again.
I'm going to leave the room and allow you to change. Please remove the shirt and you can keep the bra on. Here's a gown for you to wear. It opens in the back. This is a drape that you can place over your lap like a blanket.
And again.
I'll be back in a few minutes. I'll knock before I come in.
So draping is very different in different parts of the world and in different places where we work. I try here to be very specific with my instructions and very clear. I allow the patient to move their own gown or drape or clothing rather than me doing it for them. It's theirs, it's not mine. For a limited exam, you can ask the patient to move their clothing rather than completely getting undressed. Like if they have a spot on their low back that they want you to see, they can lift their own shirt rather than taking off their shirt and pants and everything else. It's best to give them privacy when they dressed and undress. Some places may have a curtain or a divider or a door for that, and try to expose only the minimum body surface area at any given time. We shouldn't assume that all men are comfortable taking off their shirt and being naked in front of others. We should provide tissues or paper as needed following any exam where you use lubrication. We try to knock before entering a patient's space and make sure that the patient says it's okay for you to come in. We introduce each exam component.
I'm now going to listen to the lungs using the stethoscope.
And explain why it's being done.
This is important because we need to see if you have pneumonia, which is an infection of the lungs.
We're giving a medical reason for the exam. The exam's not being done so that you can touch them or look at their bodies. It has medical purpose. Ask permission before touching sensitive areas or moving their clothing or draping.
May I open the gowns from the back slightly in order to get a more accurate listen to the lungs?
It's about doing an accurate exam, a thorough exam, and an exam that will be helpful for you to make a diagnosis. We stay within the patient's eyesight.
And at your side.
And I'll show you some examples of what this looks like. Many people think if I have to listen to the back of their lungs, I should stand behind the patient. But she can't tell where I am or what I'm doing. And so I still get the same information standing at her side. The stethoscope is long, it reaches, and now she can see where I am. Here for generations, doctors have been trained to do the thyroid exam standing directly behind the patient with the fingers fully wrapped around the neck and the thumbs in the back. And that can feel like strangulation. So why not stand at the patient's side with the fingers fully extended on the neck? Tell the patient what you're about to do and why. If you feel like you can't get accurate information that way, you can try an anterior approach from the front. For the pelvic exam, having the patient completely flat is a subordinate position and can trigger memories of abuse and assault. So we can, if the room allows for it, you can put pillows behind them, or you can elevate the exam table 15 degrees, 20 degrees. You can also offer them a mirror for the things they cannot see if that's available in your space. There's even a movement towards self-insertion of the speculum for a pelvic exam, meaning the patient puts it in on their own. There's a movement towards self-insertion of swabs for a non-speculum exam, and even self-insertion of the transvaginal ultrasound probe when you're doing an ultrasound inside the vagina. We try to respect personal space. I'll show you an example of this. When we're listening to the front of the heart, you don't necessarily have to be in front of the patient pushing up against her knees. You can still stand at her side. When we check the heart rate, try to keep your hand away from the patient's genitals. You can move their hand, they can move their hand to rest on their knee or next to them on the exam table. When you're checking blood pressure, in the first picture, I'm pushed up against her knees. She's leaning to the side, having to support her own arm. So I respect her space by standing outside of her space, and I support her arm entirely. We try not to stand blocking any doors, blocking any exits. You can do it for a few seconds, but don't have a long conversation standing above the patient and blocking their exit. Next, we try to use very simple clinical language, and I'll show you some examples.
Mouth open, take some deep breaths in and out.
Trauma-informed language should be very easy to understand. We avoid big medical terms that the patient may not understand. We try to be cautious with whatever imagery we provide. We don't know what could be triggering for the patient. I'll give you an example. We try to avoid any possible sexual connotation. We try to minimize the power differential between the patient and us. We accommodate people who speak other languages as best we can. And our word choice will be professional, not personal. I'll show you an example. This stuff makes sense to me in English. I am not able to translate this to other languages to see if it's appropriate. You would know best. But for my practice, I try to use the word the when referring to body parts rather than your. It feels a little different to hear, now I want to look at your penis, versus I will now inspect the penis. The means it's an anatomic body part that I will examine. I've examined hundreds of other such body parts. It's less personal and zoned in on the patient's body. It's more detached. Instead of saying that this is a bed with a sheet, which can frame the exam in an intimate manner, it's an exam table and this is a drape. Instead of saying, I want to do something, perhaps I'm going to, or would it be okay if I did something? Instead of, that looks good, that looks healthy. Instead of, I want to look at you, I'm going to feel this, I'm going to touch this, maybe inspect, examine, check, evaluate. If a patient appears very nervous and you're going to try to calm them down, we try not to give them any imagery. We shouldn't say, pretend you're just at home, lying in bed. We don't know what's happened to them in bed before, so we try not to do imagery. So you can say, some find it helpful to take a deep, relaxing breath. Instead of shouting at the patient to relax, maybe when you're trying to check their reflexes in their knee, you can say, allow the knees to relax. You're going to give them control over their own body parts. And for the neurologic exam, we hear phrases like, put up your arms like you're going to fight, push me away, don't let me do this. It puts the patient in conflict with the examiner. So just refer to the motion itself. Bend the elbows, push forward, resist this motion, or keep the arms up strong. During the exam, we check in periodically and as needed.
How are you doing?
We use professional touch. I'll show you examples of what that means. I like to place a firm touch on their shoulder when I'm reaching behind them, like if I need to grab the otoscope so they still know where I am in space, even if I've disappeared from their field of vision. And I place a firm hand on the shoulder when I'm listening to the back of the lungs to avoid the surprise of sensation of touch on the body. Prior to an internal exam, a vaginal exam, a rectal exam, you can say, you're going to feel my hand on the thigh to start. You're going to feel my hand on the buttocks, rather than all of a sudden internal penetration, right? Then we try to prepare patients for the sensations they may experience during the exam. You can say, this tuning fork will feel like a vibration. The speculum may feel cold. The stethoscope may feel cold. This will feel very sharp, etc. And finally, be efficient. That concludes the exam. Leah, you can read this part.
Concludes the exam. I'm going to step out now and you can get dressed. I'll be back in a few minutes so that we can discuss your results and come up with a plan together. I'll knock before I come in.
So for efficiency, we can inform the patient how long an exam will take. Maybe you can say, this rectal exam will take 10 seconds. We avoid keeping the blood pressure cuff inflated for too long, as it can resemble a restraint. Take breaks whenever you're doing an exam with a mouth in an open, fixed position to avoid triggering memories of forced oral sex. This is an important reason in our country for avoidance of dental care. And ask patients to show you a genital lesion rather than taking the time to find it yourself. They will be much faster at finding it than you. Finally, after the exam is done, that's when we
knock.
We knock. That's right. Get permission to go back into the room, and we express thanks.
Thanks very much for coming to this appointment and for helping me perform a thorough exam.
Then we discuss results once they're dressed again, not while they're naked, not while they're in the robe, once they're dressed and comfortable and seated in a chair, place of their choice.
The lungs sound clear, which is good news. You do not have pneumonia.
And finally, at the end, you can ask an open-ended question to make sure their questions are answered.
You have.
That's right. So this is just to show on one slide everything that I've shared, how to do a trauma-informed physical exam before, during, and after with our speech and our behaviors. So we'll transition to the final section of our talk today, and we're going to offer plenty of time for questions, for conversation. So this is about self-care, and Leah will guide this discussion.
Okay, you can actually, well, I guess I'll just say it is essential to talk about self-care when we talk about trauma-informed care, because providing care to heavily traumatized populations is very different from providing care to people who have not been traumatized, who are highly privileged. It's different. There are lots of things that can happen to a patient, to a provider, including secondary traumatic stress, like we talked about earlier. So let's go to the next slide to go through some strategies for helping to recover after a really difficult visit with a patient, or a really difficult day, or simply things for prevention of secondary traumatic stress. So if you've had a really challenging, like a particularly challenging encounter, it can be, if possible, it can be really helpful if you can find a calm area to self-regulate and rest between patients. I know that that's not often realistic, so I'm just putting it out there because it could help a lot if there is space to bake that in somehow to your day, or perhaps you just intentionally set aside a little time during lunch or right at the end of the day. It's also, so these are, in case you didn't notice, these are all the trauma-informed care ideas, but applied to ourselves. So in terms of trustworthiness and transparency, it's essential, really helpful, to be honest with yourself about when you're feeling symptoms of traumatic stress. Having peer support is everything. Finding like-minded and empathic professional peers to give and receive validation and support. Maybe you find somebody and you have a conversation about doing this for one another, so that when it does happen, you don't have to go through the tricky experience of trying to figure out who you can talk to about something like this. You've already got them in mind.
And I'll share here, just as I shared before, that healing happens in relationships. I find that this principle, the peer support, is the most important one. So please do look at your colleagues as peer support. You do have one another. Perhaps we can optimize the way that we use one another for supporting ourselves and supporting others. And healing happens in relationships, with your relationship with yourself, your relationship with your family, relationship with friends, relationship with coworkers, relationship with God, relation with your spirituality. So relationships everywhere should be optimized.
The one thing that I understand and that I've learned from Judith Herman's work is that interpersonal trauma heals interpersonally, which is a conundrum, but it's true, and it's also hopeful. So yes, finding ways to connect with peers who are doing similar work like today. And if you're feeling overwhelmed, know that you can ask for support and help as needed. You do not have to continue alone. What you're going through matters. And finally, it's really important to recognize that your identities affect you and are related to the traumatic material you may witness. So you may be getting triggered because of your own identities and your own experiences. And also training, like today, training is knowledge is power, both for your patients and for you. It builds a sense of empowerment and agency, which is a great way of fighting back against the forces of traumatic stress. You are still muted.
To summarize some of the things that we've mentioned today, we'd like to offer a few closing points. One is that we can all be healers. It's very important to note you do not have to be a licensed clinical therapist to be therapeutic. I'll say it again. You do not have to be a therapist to be therapeutic. We are all built with the capacity to heal ourselves and to participate in the healing of others. Expressing empathy well is a learned skill. We have a lot of it inherently, and you're all inherently compassionate individuals. You've gone into medicine for that reason, but we can all learn some more about how to do this skill successfully. Trauma-informed care is a universal precaution, meaning that we're assuming that the person in front of us has experienced difficult things, and we're just going to go in trying to create a safe space and trying to make them feel empowered and heard and valued. When in doubt and when you don't know what to do next, I find it helpful to pause and tap into a feeling inside of compassion, and whatever happens next is going to be okay. This is a quote I'd like to offer again from Judith Herman. We've been sharing a lot of her work today from that book that we typed into the chat. She says that helplessness and isolation are the core experiences of psychological trauma. Empowerment and reconnection are the core experiences of recovery. So the point is that we will all struggle to a degree in this mortal life. And we not only have to care for ourselves when we go through something difficult, but we have to care for others, because the hard and beautiful responsibility of living on this planet is that we are in this together. So now we'll allow some time and space for discussion. We welcome people to unmute themselves. You can share out loud. You can also share in the chat, either to everyone, or you can send us an anonymous message personally. We welcome whatever you'd like to share and discuss. And thank you so much for your time.
Thank you. Thank you so much, both of you. Really very good, informative presentation. Dr. Udina, are you there? Maybe you can lead the discussion. There was one question I saw in the chat. Maybe we can start with that.
Yeah, hello, can you hear me?
Yes.
Yes.
Great. Yeah, thank you so much again. It is such a powerful presentation, and you know, I have attended this presentation, but I always learn something new, and it's really powerful for you to share such expertise and experience and knowledge, and this will be many to come, I think, and given the challenges that's going on in Ethiopia. So I think there was a question about some public health level intervention, and that I think Leah mentioned. You shared some information, some tools, screening tools. There's going to be a section on that from Professor Jonas and Dr. Ida, but Leah or Dr. LCO, if you want to add to that, feel free.
One thing I'll point out is there's a resource called the Trauma Resource Institute that has a community resiliency model training that I've heard great things about, and I've even heard of it used in the Middle East and around the world by some of my colleagues who work with refugees. And we use it here at CHA as a group model. So I might recommend taking a look at that resource. I'm sure there are others like it out there.
If we're not, in the absence of finding a training, Lee and I will do our best to compile a collection of resources after this talk, in addition to our slides, that hopefully will be useful to share with patients or your facility at large from a public health standpoint.
Great. Yeah, and we focused, as I mentioned, sharing really extensive background and the experience that you both have at the VA, where we have mostly retired soldiers who have seen so many trauma, and also Leah working with refugees, immigrants with so many trauma, and so we wanted to have that platform to share that experience and expertise. And then Professor Jonas and Dr. Ida will share next in terms of in the context of and the cultural sensitivity in Ethiopia, the next sections.
Yeah, one thing that comes to mind as you mention that is that it really doesn't matter too much what specific event someone has experienced. It all manifests in very similar ways. We have one human brain and one human body. So the brain responds in very predictable ways to severe stress. And the brain governs the health of the body, and then that governs our behaviors. So it doesn't really matter asking somebody, so what happened next, and what specifically happened next, and then what happened next. It's not like taking a history where you want to know the severity of their knee pain and how they twisted it and did it get red and swollen. What matters is how that past event has impacted them today, and that's what you're going to focus on. And healing can happen in any moment. I'll share with you, so I didn't plan to share this today, but it's coming to mind today. So I'll share with you something that happened this week with a patient. He came to me for acupuncture in the ears. We've been trained to do acupuncture in the ears here at the military hospital where I work. And it was for his chronic knee and back and neck pain. Okay, routine. But he said that later that afternoon, he was driving to Vermont, a couple hours away, to visit his son's grave. This man is in his 50s. His son died when he was young from a genetic disorder. The anniversary of his son's death was a couple days prior. The following day was his new son's birthday, and the day when he saw me was his dead son's birthday. So April is a hard month. And he said, we should talk about something else, because he was feeling himself become dysregulated. He was about to cry. So we did the acupuncture, but then I circled back and I asked him, how do you typically celebrate your son's birthday? How do you celebrate your son's life? Who do you have in your life to support you when you are feeling hard feelings. And we talked about the love he has with his wife. We talked about how he used to love working on machines, how he loved to go fishing, but he hasn't done it in a long time. And I encouraged him to re-engage in the things that make him feel alive. And I asked him, what's your favorite color? And he said, red. I remember months ago, a nurse had sent me these little hearts that she weaves with thread, and she sometimes gives them to her patients. I had 2 left in my office. One of them was red. So I gave it to the patient and I said, this is to remind you that your son's memory is eternal. And he thanked me. And 2 days later, he sent me a message thanking me for the heart and letting me know that he put it in the ground with his son, that it felt right to leave it there. And so look at that. I had a basic primary care appointment when I could have just talked about the guy's knee, did what I needed to do and left. But that wasn't the issue at hand. The issue at hand was emotional pain and the need for emotional and spiritual healing. You are all equipped to communicate care and transform a person's day and life. So that's what I wanted to share. And thank you for that space.
Thank you so much again. And as you mentioned earlier, it is so powerful, and anyone can do this, right? Anyone can help. And so it's not just for our physicians, it's not just for medical students. And so anyone can have an impact. And so that is what I really got out of this session. I think there's one question. I think you already answered it in the context and the chat. Given the Ethiopian, what kind of trauma-informed care design you will recommend? If you have any, I think we already touched on this.
Yeah, I think that's a good and complicated question that probably depends on the resources in the community that was most affected, but there are lots of ways that you could apply trauma-informed care to a community.
And we'll circle back with the resources that we have at our disposal, and hopefully something will prove useful and able to be integrated.
One thing I will say is that group care can be pretty wonderful and profound in trauma care, gathering together people who have been similarly affected by an event and creating a safe space to talk about the impact of trauma on present day life and how we can take care of ourselves in light of that. Not getting into all the details of the trauma in a group space, but talking about present day impact and strategies for self-care. That's another way to greatly reduce shame when people see that the things they're experiencing are being experienced by many other people in their community.
Great. And we touched on one of the idea of this session also to make sure to destigmatize and to humanize mental health and mental well-being. And so that's.
I heard something by a trauma expert that really stuck with me. And he said, it's unfortunate that we call it mental health because there's no organ in the body called the mental. This is our brain's health. This is very real. This is tangible. This is happening to you as it would happen to many other human brains who experience severe stress. And so that can be really powerful for people. I've heard many patients tell me, oh my goodness, I thought that I was just crazy. So you're telling me this is real. So you're telling me I'm not making this up. I said, no, This is real and you're not making it up. And even that can be freeing for people.
Just to piggyback off of that, sharing with people that traumatic stress, I think I said this earlier, but just to reinforce, is an injury, not an illness. It's in many ways unfortunate, sort of, that it's a diagnosis. It's that it's clustered with other things that are more mental. So injury over illness, and also, psychiatry, I believe used to be under, at least in the US, it used to be under the umbrella of neurology. So it's about the study of the brain. I think that's a great point, talking about it in terms of a brain injury, which sounds scary, but it's, luckily it can heal.
Great.
I have a question. Probably this is, I'm not in the field, but do you have a different strategy for children versus adult or adolescent in terms of trauma management?
A little bit. A lot of trauma informed care or trauma treatment for children is really family treatment. So you see anything that you would be doing with the child, you would also be doing with a parent, whoever their caretaker. You'd be teaching the parent about the impacts of trauma on children and ways that they can help the child regulate and help the child gain agency over the difficult sensations that are happening in their body. And there's a lot of wonderful children's books in the US in English that teach children about trauma, that, hopefully there's something similar. And in general, children work through their trauma through play and in indirect ways. When they have a safe space, people do actually heal naturally from trauma when they're given a safe space to exist.
Yes. One thing that I have learned, I don't take care of children in my clinical practice, but when we see children who are shouting or fighting, they're not bad kids, right? These are kids who are becoming dysregulated, and they may not yet in their development or through their experience know how to express it verbally. They may not have been given the language to say, I am feeling angry, I have resentment, I feel betrayed, right? These are tough words. And so helping them to recognize the feeling that's in the body and maybe emotions attached to that, and then giving them tools for regulation, which, as Leah mentioned, is usually through play. Let's color. We love colors. Let's smell the crayons. That's calming. Let's have a tight squeeze and a hug. Let's cuddle with my favorite blanket and stuffed animal. All of that helps them to regulate and be calm and present in the moment. You all know probably that many of us spend our lives living in two places: the past, where we are replaying negative, horrible experiences, or in the future, where we are worried about potentially more horrible experiences. But when are we ever right here in the present, where we actually are pretty safe right now?
Oh, it's great. Any other question people have?
I don't have a question, but I just wanted to say thank you to both of you for such an incredible training. I work in primary care and work at a federally qualified health center where I have a lot of patients who've experienced trauma. And it was really powerful for me to see how we can use things like the NURSE acronym to show empathy, and how just listening and validating feelings and being very intentional about our physical exam can be healing. So I'm in a situation where sometimes our patients, face a lot of barriers and don't have access to therapist or a counselor or mental health resources. And sometimes I feel stuck. And so it's really nice to see that just listening, just being there and bearing witness to the trauma that people have experienced can be healing. So thank you.
That's it. Thank you for that beautiful comment. It means a lot. For me, verbal expressions of empathy and learning the NURSE acronym, that's the most powerful tool in my toolbox as a physician. It's not my prescription pad. It's not the beta blocker. I think that being present with people and offering empathy is my superhero power.
Yes, and something that we can definitely apply, I think, in Ethiopia in a very resource limited setting. I know that was a question that came up, but I said just a general practitioner, you can have a lot of power by giving your time and
That's
empathy.
it.
Yeah,
That's
so
it.
thank you.
That's it, because it's love that heals.
Yes.
Thank you so much again, and I'm thinking there's going to be a lot more we will need to do in the future and collaborate and training and workshops, and so I want to thank Dr. Elisiu and Leah Sarame again, and then if you don't have any last minute comment, we'll go to the next session.
Thank you.
Thank you so much.
Thank you all so much. Leah and I are headed to clinic, so we'll circle back. We'll see you next time.
Thank you.
Thank you so much. All right, thank you so much, Dr. Nahum. It's very, very powerful and personal experience on this big issue we are facing. So the next session, we move to Professor Jonas Geda, and he's going to talk about user-friendly and evidence-based psychosocial intervention. And I'm sure most of you know, but just for sake of introduction, Professor Jonas, he got his medical degree from Addis Ababa University, and then he completed his residency in psychiatry, followed by a fellowship in behavioral neurology at Mayo Clinic in Minnesota. So Mayo Clinic is one of the leading medical institutions in the US. Following his training, he was a full faculty and promoted to professor of neurology and psychiatry at Mayo Clinic. And he has been there in Minnesota for about 25 years. And I think very recently a few years back, he moved to leadership position to Barrow Neurological Institute in Arizona as a professor and director of global neuroscience and mental health program. He is currently he has active clinical practice in the division of Alzheimer's disease and memory disorder program in the Department of Neurology and Behavior at Barrow Neurological Institute. And he's very active in teaching and directing the global behavioral neurology program, fellowship program, and he's really very, very active in research and has over 160 peer-reviewed publication mostly in high impact factor journals, including JAMA Neurology, JAMA Psychiatry, American Journal of Psychiatry and Neurology. And he, most importantly, has dedicated most of his time to train Ethiopian nationals and here in the US and also traveling and through the P2P program he's actively involved with, to share his experience and train younger generation. So without further ado, Professor Jonas, thank you for joining us.
Thank you, Professor Tesfaye. So good evening, good afternoon in Ethiopia. So let me share my slide. Okay, see here. So you can see my slides, correct?
Yes, perfectly.
Very good. Okay, so I will be talking about traumatic stress and armed conflict. So what is to be done, KFAIR, from a mental health perspective? As Professor Tesfaye said, I'm at Barrow Neurological Institute now. I'm also a research professor at Center for Bioelectronics and Biosensors at Arizona State University. All right. So what I will do is I will talk about stress. And already we had really a great talk on approach from the Harvard group. Therefore, we don't need to go into trauma. But we will, after I talk about stress model, then we will talk about evidence-based user-friendly approach. And I will share with you some of the work that is done based on that model among South Sudanese refugees and among refugees and trauma survivors in Syria. So we all know emotion, thoughts, and behavior are interrelated. So there is emotions lead to thoughts, thoughts to behavior, behavior to emotion. They are very much interrelated. So let us use a very simplistic model. So the ABC model. So this is a very good take home. So there is an adverse event. So the armed conflict in Ethiopia that started on November 4 of 2020 is really the armed conflict. So the war was in the region called Tigray, for those of you who are not from Ethiopia, from November 2020 up to June 28, 2021, the war was in one region. And then after June 2021, it involved two neighboring regions called the Afar and Amhara regions. So that is the adverse event part. So the consequences, emotional behavior, those things we call C, emotional consequence. And then between an adverse event and trauma and emotional consequence, there is always one's implicit or explicit evaluation of an adverse event. So regarding this war and trauma, a person, an individual has his own, her own analysis about the situation. So that's the B part, the belief of the individual. So this is, okay. So the next question is, does A lead to C? Is there anything else between A and C? Let us suppose that 100 persons are exposed to horrific traumatic stress. Example, rape, death threat, witnessing horrific death, that will be adverse event. The question is, do all the 100 persons develop excessive negative emotion or post-traumatic stress disorder? As the speaker said earlier, out of 100 people who experienced severe trauma, after 6 months, about 7% will develop PTSD, not everybody. So what are the factors that make a person vulnerable to PTSD? So Out of 100 people, some will experience transient angers and take action. Example, get organized to defend their village. So during the war, we have heard lots of stories. So some people were helpless and they were bound at home, and they are not able to function. On the other hand, some of those who are exposed to the trauma, they became determined to defend their village, their neighborhood to the last. And this gives them a sense of purpose. And it prevented the helplessness sensation. Some may experience overwhelming anger that prevents them from taking action. They get immobilized by excessive and incapacitating anger. Some may feel helpless and hopeless, thereby developing PTSD and comorbid mood disorders. So why is it all 100 did not have the same emotional consequence? There is a B between A and C. So a person's belief or world outlook, there is a cognitive triad. So I, others, and the world, the three frames of reference. So a person who has extremely rigid rule about oneself, extremely rigid rule about oneself. So let me see, somebody has raised his hand, Dr. Indalo Gizacho. I will let Dr. Wooduna communicate through chat room. So B, one's implicit or explicit evaluation of an adverse event. The B has three components. Number one, I, for example, extremely rigid rule about oneself. I must be loved by others. Others must not be unfair to me. This is another extremely rigid rule for other persons. So if I have a very strong, strict rule for others by saying that others should never be unfair to me, that's one extremely rigid rule. The third one is about the world. We may have extremely rigid rules. The civilized world must be fair and balanced. Democratic countries should not be creating and spreading fake news. I remember the extreme anger in Ethiopia and in diaspora when the famous CNN, Central News Network, transmitted news by saying, we're transmitting this news from outside Addis Ababa. And the rebels are about to capture Addis Ababa. This was in November. And Addis Ababa is about to fall. Then it turned out the video was not even from around Addis Ababa. And yet CNN would not retract that news. There was an extreme disappointment. And most people, I asked them, why are you so upset? Because they said, from a democratic, from a free press, we do not expect this. So that's really, when we have extremely rigid rule for the world, then we are bound to have these types of emotional reactions. So three cognitive triads about oneself, extremely rigid rule about oneself, about others, and the world. So what determines a person's belief? Of course, the phase factor, the person's phase, the person's conscious cultivation of world outlook, past emotional, physical trauma, and of course, biological, genetics, all of those things are factors. And then of course, growth and development, usually implicit bias, automatic implicit bias are usually rooted in childhood. And then, of course, role models, for example, in the northern part of it, of course, in Ethiopia in general, heroism at the battlefront is valued. If a general loses war and commits suicide in the Ethiopian context, that is is considered that is a role model. So we all know about Emperor Theodorus. So he is, in every school child knows about his heroism. And instead of surrendering to the conquering British forces, he committed suicide. And these types of stories embedded in our culture are part of our belief system. That's how we form our belief system. So now I want to take you to this intervention called ACT, Acceptance and Commitment Therapy. Why did we select ACT? It was, of course, the study, the work done in South Sudan was used based on ACT intervention. WHO used it. And I was exposed to it in 2011 at Mayo Clinic. There was a speaker, invited Professor Stephen Hayes to give a talk. And he said, the existing cognitive behavioral therapy is very good, but emotions are not given that much weight. He said, additionally, he said, the therapy system is highly regulated by professional societies. So he wanted to develop a model that can be disseminated, that anyone can be trained in ACT intervention. It's not limited to psychiatrists, psychologists, social workers. Any one of you in this audience can get ACT training. So that really caught my attention. Okay, perhaps this is the type of thing we need in Ethiopia, because we have so much need, 120 million population. We probably have 50 or 60 psychiatrists or 14, 15 psychologists. So that's what caught my attention. So what is ACT? So I will briefly introduce you to the concept of ACT. So it's one of the thing about ACT is that it has only 6 domains, 6 processes. When Professor Stephen Hayes sees a patient, he will give them value living questionnaire. He will be asking them, what do you live for? And then, is there lack of values? Is there lack of clarity? And then, is there dominance of past stories? So we will come to this, but these are the 6 components. So he also noted, he and these others did in their work, they noted that human beings in general, that the normal state of the human mind should be healthy, content, and happy. Psychological pain is therefore abnormal and needs to be fixed or deleted. Whereas the ACT approach on suffering is that the normal psychological process of humans could often be destructive and can create psychological suffering. Suffering is more of being stuck, not necessarily sick. So the psychological flexibility model links psychopathology, psychological health, psychological intervention. And we will come to this model. Okay. So, let's start with this. First component is value clarification, or purpose, and how we want to live our lives. What type of person do you want to be? It's not necessarily where you are now, but what type of person do you want to be? What type of things do you value? Do you value hard work, commitment, compassion, respect, etc.? So there is a value delivery. Do you value taking care of your physical self-health? So we'll look at some of the questionnaire later on. And then if you do, then how about, do you practice what you preach? Committed action. So are you moving in the direction of the type of person you want to be? Or are you moving away from the type of person you want to be? And then there is this self as context. Usually people get fused with their own story. I am quote unquote lazy. I am this, I am that. these types of getting fused with one's own story could be handicapping, could become a self-fulfilling prophecy. And instead of saying, I am a person who could be procrastinating sometimes, meeting deadlines at other times. So rather than focusing on specific behaviors, people tend to get fused with their own story, and that becomes self-sabotaging. And then one thing that Professor Hayes and others developed a new concept, cognitive diffusion. So for example, a college student in some of their study, all of a sudden says, well, this is a difficult course. I'm going to fail this course. This is fusion. The student gets fused with this type of attitude to the course. So the problem with cognitive fusion is that it hampers behavior, it sabotages actions that can take the person in the direction of passing the exam. So if the student gets fused, day number one, by saying, well, I will fail this course, then instead of going to library, the student is probably more likely to go to a bar and drink alcohol. So instead of cognitive fusion, cognitive diffusion. So they came up with a very simple intervention. What they did is they would rewrite it as saying, I am having the thought of, quote, I'm going to fail this course, unquote. That very simple sentence, I'm having the thought of, creates a distance between the self-sabotaging view and the individual. In fact, this diffusion, they call it. So diffusion is the opposite of fusion in their technical term. In fact, this was used in a famous trial in state of Washington, where in the West Coast, I think the neighboring state of Dr. Woodner, and in the place where Dr. Daniel lives, there was a study on tobacco cessation. They just used cognitive diffusion, one single strategy. And instead of saying, okay, I'm craving for tobacco, I need to go for it, they will be saying, I am having the thought of, quote, craving for tobacco. That simple delay, that simple detachment, that simple distance was able to predict staying in remission or staying out of tobacco cigarette consumption. The other key concept that they have identified, extremely important, is once a person identifies what is valuable, for example, let's say members of Alliance for Research, Innovation, and Education, they value obviously research, they value education. So a member of that group would say, okay, I value research, I'm going to study the mental health problems in northern Ethiopia, and I want to come up with some concrete plan. So this is a value direction. And then at the same time, the person has to make room for uncomfortable emotions. They should be willing to make room for uncomfortable emotions, because there could be bureaucratic red tape in the US, in Ethiopia, to get to the point you want to be. There could be 100 people who want to help you achieve your great goal. There will be 200 people who will try to delay you and frustrate you or sabotage your great value or direction. So that's where they introduce the term of willingness. Are you willing to make room for uncomfortable emotion in the service of moving in the direction of your valued life? So they call it willingness or acceptance. So it has to be linked. Willingness has to be linked with valued living. In the service of valued living, are you willing to make room for uncomfortable emotions? I always hear in our, COVID-19 Advisory Council, in various situations, we hear frustrations, in both directions. From home, I hear frustrations about, diaspora, trying to do things at fast pace without following the due process of completing paperwork at the airports, etc. And then on the US side, I hear, here we are trying to help our country, but the bureaucracy is delaying it. We cannot even get things out of the airport to the community. So there are lots of things. So this is frustration, anger. So we have the person's goal is to help our community at grassroots level. In the process, the person may need to be willing to make room for uncomfortable emotions. So and then the other one is, as Dr. Sadi and Dr. Leah earlier mentioned, we tend to spend a lot of time about worrying about the future, what is coming in the future, what will happen to me, to my family, to my country, to my community, to my region, to my, maybe in the Ethiopian case nowadays, to my ethnicity. People seem to be thinking along that line. So, and then other one is spending too much time in the past, loss, ruminating about loss, about hurt. So and so did this to me. And then spending less time in the present. So cultivating contact with the present moment. So really, we humans have tremendous, Joseph Ledoux, who has done tremendous work on fear behavior, fear conditioning, and anxiety. He says, we humans are endowed with the ability to plan for the future, with the ability to anticipate the future, with the ability to think of the future, and that itself seems to bring about, makes us vulnerable to anxiety as well. So I think these are these are the 6 models. In short: value clarification, willingness, making room for uncomfortable emotion in the service of valid living, committed action, and fusion. And then the opposite is diffusion. And instead of being, self as content, instead of self as content, instead of getting fused with self stories, self as context. I am, above. So a person is above the sum of small events. So these are the 6 components. So we can kind of divide the 6 components into 2 major categories. So the value clarification, committed action, and attention to present could be behavioral actions, and this one's more of mindfulness and acceptance. We can also divide them into 3 categories. So one of them is being open to one's experience. Instead of hiding, running away, to be open, and then centered, present moment, and then engaged. So value clarification, committed action. So I already explained this. We don't need to go into that. So how do we measure this? So really for value, we have value clarification. So we will look at this questionnaire. For committed action, there is a bull's eye exercise that we are going to look at. And then for cognitive fusion, there is a very simple 5 questions. And then about how much time do you spend in the present moment, in the future, in the past. So let me see. For example, the cognitive fusion questionnaire, it asks never true, seldom true, always true. I get so caught up in my thoughts that I am unable to do the things that I most want to do. For example, a student wants to do well on an exam, and therefore the student knows that he or she has to study and has to go to library, purchase the right material, sit down and work. And instead, the student may get caught up in the hurt and anger for rejection the student faced when approaching a girlfriend or boyfriend, whatever direction. So this is what is called cognitive fusion questionnaire. So on the other hand, does the person make room for uncomfortable emotion and pursue the valued living? Okay, we have attachment to a conceptualized self versus ongoing awareness and perspective taking. So this is what I told you. Some people, they classify themselves, I am lazy, I am stupid, I am this, I am that. They get so attached to this conceptualized self instead of being aware. So I am having this behavior, I have done this behavior, but I am the person who will engage in something positive, something negative, something neutral. So that we know that is the case. So so conceptualize self as context. Fusion with concept leads to interference with psychological flexibility. Okay. Let's not get too much into this. So I have explained these concepts. So engaged response style. So this is both valued living and committed action. So values are verbally constructed and undergo ongoing review, allows focus on generating psychological purpose and meaning. So the one thing I like about ACT intervention really is you don't see too much of this psychological terms, and these are value clarification, committed action. These are, anybody can relate to these constructs and concepts. So let's say a person called Bob identifies important values, connecting with others. Bob suffers from social anxiety, does not get out of the house. So through this ACT intervention, he values connection, then he's learning to be authentic and genuine. Usually in social anxiety, they have fear of evaluation anxieties. They have fear of how others view them, how others think about them. So that's one of the things addressed using ACT. So if taking your life in the direction of these values means you need to make room for feelings of anxiety, are you willing to do that? So this is a question that the ACT interventionist asks Bob. So instead of committed action, there could be inaction, a tendency to feel overwhelmed by a task instead of starting, in a small piece. So I think one of the motto of the Dr. Tesfaye has shared with me, the motto of the Alliance for Research and Innovation and Education is, we think big, but act small. We start in a small place, in one specific place. You start with one clinic, with one university, and then slowly you build your experience on that and you move. That is basically action, committed action. But from day number one, if you want to work with Ministry of Health, with Tukur Ambassa, with Bahir Dar, with Dila, with Jijiga University, so that's really overly ambitious, overwhelming, and probably you won't go anywhere. So when you don't make any progress, then it reinforces further inaction. So that's what's meant by inaction. Another factor is impulsivity versus valued, intentional move. So Okay. So committed action, one of the things is, so you have action, number one, and also action tendency, or the step you are going to take toward this, the specific action. So ACT really does not try to get rid of bad feelings or get over all trauma. It's about creating valued living. So the person will define what the person wants to live for. And then the person has to be willing to make room for uncomfortable emotions and do specific actions. Bob still experiences anxiety and still has negative thoughts, however, is not controlled by them. Anxiety is diminished and does not distract, and willingness of feelings give control back to him. Ironically, he has more control by practicing willingness than by experiential avoidance. So I want to talk to you a little bit about the application of this ACT intervention among refugees. But before I go into that, Dr. Woodina, I don't know, how do you want to proceed? Shall we have the discussion after this, or you want to give some chance for people to ask a few questions?
Maybe you can finish your part.
Okay, good. We'll do that.
Yeah.
Okay. So Dr. Russ Harris, he is one of the well-known ACT experts. Actually, Dr. Harris, he was either a movie star or he was an artist, actor of some sort in UK, United Kingdom. Then he pursued medicine. He became a general practitioner, GP. This is public knowledge, basically. He says it publicly, so that's why I'm sharing. And then his son developed autism. So he wanted help for his son. So it turned out there is an expert in Australia, so he went to Australia. So this expert in Australia on autism and spectrum uses ACT intervention. So specifically, there is something called relational frame theory. And then his son improved. Actually, his son is now verbal. He is an adult. He has pursued college education. So Dr. Harris, a very brilliant man, so he studied this thing, and he got more training in ACT. And now Dr. Harris is giving more training. In fact, it was his manual that was used by WHO in South Sudanese refugees. And actually, there is a 6 weeks training in ACT intervention. So in Ethiopia, Professor Mesfin Araya, Dr. Tafarra Bayero, so my colleague, we were together at General Wingate Secondary School in the old days, and Dr. Aida Tafarra, the young psychiatrist, and I think a couple of other people did get this training, the online trainings, that the 6 weeks trainings that Dr. Russ Harris gives. So his model was used in refugee camps. These are Sudanese refugees, South Sudanese refugees in Uganda. So this finding was published in Lancet Global Health in 2020. So the most women had experienced repeated gender-based violence, as well as horrors of warfare and ongoing stress of living in a camp of 250,000 refugees. So now war trauma is close to all of us. So because of the war going on in northern Ethiopia, in a very large landmass, a landmass as big as Germany or as many European countries together. So It's a large involving millions of people, 7 million, 8 million, or 15 million people. So we have also heard of horrors of gender-based violence in Ethiopia. So we can now, this is no more, the story about Southern Sudanese refugees is no more a distant story. It is our own story as well. And so this intervention involves a target group. So there was 10 hours of ACT. It was delivered in a group program. It was run by lay facilitators, not by psychiatrists, psychologists, lay persons. And it resulted in significant reduction in both PTSD symptoms and depression. Even though, as I told you, the primary goal of ACT is not to delete symptoms. It is rather to cultivate valued living, committed action, willingness in the service of valued living. But as the person pursues those things, secondarily symptoms go down. In fact, ACT has been used even in psychotic patients. A person called Patricia Bach, B-A-C-H, at the University of Illinois in Chicago. She used ACT intervention among psychotic schizophrenic patients. And the study showed that it prevented readmission rate significantly. However, the awareness of the psychotic patients about hallucinations and delusions increased. So they reported more hallucination and delusions. That's because they were more in tune with their thoughts. And instead of experiential avoidance, they were more in tune with their emotions and thoughts and behavior. So it has been used. So the primary goal is value clarification, committed action, and willingness, cultivating those skills. Secondarily, symptoms get reduced. So stage one, so 1 to 2 sessions, they take history, they talk about, informed consent, are you willing to participate in this? They establish goals, and then there is psychoeducation on trauma in a very simple, concrete terms. And there is something called dropping anchor exercise. So basically, there is this audio that the group listens. I will put it up later on. We will have an experience on the dropping anchor. Then living in the present, they start with that exercise. Then I told you they exercise about, instead of fusion, diffusion, and then acceptance, self-compassion, clarifying values, committed action, breaking destructive patterns, then healing the past. So there are these different grieving, forgiving, exposure to traumatic memories, building the future, long-term goals, ending therapy. So these are the things. So basically, this is on ACT. So I think earlier I told you in the ABC model, A is adverse event, C is emotional consequence, and B is a person's belief. So I think in the current day Ethiopia, some of the work in social psychology, Dr. Aronson in Stanford and at University of Michigan, the very famous social psychologist, originally from Jamaica, he and many others have done a lot of work on group behavior. So I just want to propose a theoretical model that one of the problems in Ethiopia could be related to this model. So I told you about ABC model. B is a person's implicit or explicit interpretation of adverse event, and then one possible contributing factor to conflicts in Ethiopia since 1992, between 92 and now, there have been really unprecedented in the history of Ethiopia, unprecedented group conflicts, ethnic conflicts. And I grew up in Sidamo, Irgachafe, Dilla, Hagaramaria. I have seen small skirmishes. My father was a governor of Hagaramaria. He used to go, he would take just one soldier, he will drive into the rural community, he will hold Auchachin for a month, they resolve, he comes back. Now you need 2 brigades to go to this community. So it's really unprecedented. So why is that? One of the social psychology model I would like to propose is overemphasis on differences and devaluing group cohesion. So in social psychology, you have to balance group cohesiveness and diversity. Although both group cohesiveness and diversity are integral components of a productive group, too much of either will interfere with optimal performance. So most of these studies are done in different group setting, but I think this could be a relevant theoretical model. A group should have enough in common to be compelled to work together and complete a task, but should also be diverse enough in that they bring new perspective and innovation to the project. So for example, if you have a team of researchers, one could be a neuroscientist, one could be genetics expert, one could be epidemiologist. So these are diverse experts, and they come together, and then the cohesion is the common research agenda. So that's a good example of balancing group cohesiveness and diversity. So this is, if you apply it, this has also been studied done in ethnographic studies as well. And so I think part of the issue is that there is overemphasis on the diversity aspect and people over-identifying with their ethnic group, excessively identifying and then neglecting the cohesiveness of the whole country, the sense of identity as a country. That cohesiveness gets diminished, and primarily focusing on excessive focus on diversity. And this takes us to what Irving Janis, Janis, he was actually a research scientist, research psychologist, neuroscientist at Stanford. But he was very curious. He said, why is that sometimes destructive decisions are made? Why did the US government, a superpower, lost a battle at the Bay of Pigs to Cubans in 1960 or something? Why did the US lose the war in Vietnam? Is there any psychological group behavior model we can look into other than political and other economic, etc. issues, military issues? So he studied that. What he found out is that during the Bay of Pigs, there was advisory group that was making decision, which was led by President John Kennedy. So John F. Kennedy, of course, is a charismatic leader, very persuasive speaker. And the members of his advisors were really Rhodes scholars, Harvard scholars, well-educated people, very independent-minded people. Whereas in that group setting, everybody sensed what Kennedy wanted. And then conformist, conscious or unconsciously, people started to conform to what Kennedy wanted to do. Therefore, everybody started to support, say yes, when a dangerous decision was being made. Sure enough, they went and they lost at the Battle of Pigs to a very to a new Cuban government. Another one was the same advisors, they were discussing about Vietnam. So they slowly started to escalate the involvement of the United States in Vietnam. And this eventually led to a destructive outcome. Whereas, on the other hand, the Cuban Missile Crisis was successful. Why? Because the advisory group intentionally decided to identify a devil's advocate. I think it was John Kennedy's brother, Robert Kennedy. Of course, you know, he's your brother, so he will not kill you. So Robert Kennedy, I think, was challenging every major idea that was coming to the table. And as you know, the Cuban Missile Crisis was very successful, the way it was handled by the US government. So groupthink that's where people in groupthink, it's a highly cohesive group. They are thinking as one person, usually in the presence of a charismatic leader, a directive leader, a leader who is not shy to dominate, to come up with great ideas, and yet does not have a challenging voice in the group. So just a second, I think there is some noise. Okay, so this is what Irving Yanis called groupthink. And so it's how do we deal with groupthink? So the other problem with groupthink, people, excessive cohesiveness, the group member tends to overestimate they have this illusion of not being vulnerable. So I think in the armed conflict in Ethiopia, most likely on November 4, the people who started the war, the groups that started the war, they were very sure of winning. Otherwise, I don't think they would have made this blitzkrieg attack, they call it preemptive strike against the Northern Command, because they felt that they are being encircled by Ethiopian government, Eritrea, and that's how they perceived it. Therefore, before they attack us, let's attack them. So they had this sense of invulnerability. So they believe in groups' inherent morality. We have the truth in our hand. We have the upper hand. We are advocating for this and that cause, whereas the Ethiopian and Eritreans are advocating for that or those, for oppression, etc. So this is overestimation of the group. The other problem with groupthink, there is a tendency to be closed-minded. There is collective rationalization. The group starts to think the same way. We started the war because we were threatened, encircled, the Amhara from the west, the Eritrea from the north, this one from the east. They were coming. So they reached out to as many people as possible to help them fight back. And then there is also a stereotype about outgroups. So in-group, out-group bias. So the others versus us. So this is the type 2. And then the third one is pressure towards uniformity. So people try to engage in self-censorship to fit into the group. They stop voicing opposition. I am sure November 4, if there was someone who was objecting the blitzkrieg, the surprise attack within that group, I don't think there was one. If there was one, probably the person could be killed by now. So this illusion of unanimity, direct pressure, putting pressure on dissenting voice within the group. And then, of course, self-appointed mind guards. There will be a few people who say, okay, you are not following the vision of the great leader or the beloved leader, just etc. These are the type of model that has been used. So in China, in various situations, this has been observed. So I think this group think could be a relevant issue. So how do we prevent groupthink? So leaders should encourage open climate of giving and accepting criticism. Leaders should be impartial and refrain from stating personal preferences, particularly prematurely. Establish multiple groups with different leaders to work the question in parallel. So each member should privately discuss current issues and options with trusted associates. From time to time, bring in outside experts to challenge the views of the core members. There should be one or more devil's advocates. I think number 7 would be extremely important. Advocates during every group meeting. In conflict situation, extra time should be devoted to interpreting warning signals from rivals and to constructing alternative scenarios of their intentions. Reconsider the decision in second chance meetings before going public. So there are ways of preventing groupthink, at least based on studies done, Rose and others have published on this. So I would like to give acknowledgement. So I had a lot of help. Well, always in research, as you all know, you have to have a very strong team. And when the team member is very productive, does not even want to be on slide 1, just at the last, a small acknowledgement, that's how you become more productive. So thank you very much. That's what I have, and then we can proceed to the discussion.
Thank you so much. This is really wonderful presentation, especially the idea of how we get out of the group thinking. All these things are really important. And I think we'll open for discussion for a few minutes and then continue with Dr. Aida. So anyone, you can unmute yourself, and you can talk in Amharic or in English. So I think most of us, we can understand each other now.
Okay. I will invite someone, but first, thank you, Dr. Jonas. For those of you who don't know him, he's been trying to do a lot of work back home in Ethiopia, and we've been discussing a lot of things. He has a lot of plans. I just pasted my email on the chat, so we need a lot of information from the local people, what the problems are. Dr. Jonas, Dr. Tasfai, Dr. Udina, and I, and others in the group are thinking about writing papers, really bringing the problems out. So we will do that. Please just keep contacting us.
I think if there's no further discussion on this, we move to our next speaker. And next speaker is Dr. Aida Tafara. So Dr. Aida, she received her Dr. MD, Doctor of Medicine from Addis Ababa University. She completed her residency in psychiatry at St. Paul Millennium Medical College in Addis. And she's now the chair of the psychiatry department at Al-Kakotebe General Hospital, which is actually dedicated. Most of the service of this hospital is related to mental health. So it's really pioneering work doing that hospital. She supervised inpatient service, which comprise over 150 beds at that hospital. and they serve over 5 million people around that catchment area. So it's one of the big one. She's a member of the National Medical Health and Psychosocial Support Advisory Council. So she has up-to-date information what's going on in the country, especially in the conflict area. So thank you, Dr. Aida. I will look forward to hear your talk.
Thank you, Professor Tesfaye, for the kindness of the introduction. I'll share my slides now. So these are my topics that I'll be discussing. So I'll give you a brief introduction about resilience. I'll try to see the different definition of resilience. We'll see about determinants of resilience, and also discuss upon some of the effective ways to enhance resilience, and also touch upon community resilience. And I'll briefly go and see about the source of resilience in the current Ethiopian context. And finally, we'll take a look on some courage stories, inspiring stories from people who have been through the war. So as an introduction, stress is a reality of our daily life, but people will be exposed to certain amount of stress or even potentially life-threatening adversities which can affect their well-being. So these adversities, it could be interpersonal violence, it could be trauma, it could be death or natural disasters. I try to show you this picture that the woman is on this unstable board and also juggling a ball. So, people go through such difficulties in life. It's a fact of life, but it does not have to be a life sentence. This is by Peter Levine, a biophysicist and a psychologist from UC Berkeley. So he urged people to pass through trauma in a way that it does not shake their whole stability and their well-being. And one fact about the human brain is that it has a unique ability to form newer connections and change structurally in response to new experiences. This is what we refer to the post-traumatic growth. So the human brain has this capacity or this resilience to go through trauma. Of course, there will be some rough patches, but the brain can make it through emotional difficulties and psychological difficulties. So the conflict in the northern part of Ethiopia has brought about immense amount of crisis, both psychological, social, economic, and you name it. But the mental health and psychosocial problem is on the rise. As it was stated by my colleagues at ALERT and at Ministry of Health, Dr. Nahum and Dr. Gannet, they have been witnessing what's going on the ground. And this study, it was done in 2020 at Gedio Zone from the internally displaced people at Gedio Zone, and it has shown that there is a significant amount of the magnitude and prevalence of depression, anxiety, trauma is on the rise. So people who are living in these conflict-affected areas, they are prone to develop post-traumatic stress. So does that mean they are, are they sentenced to live by that diagnosis? or what's going to happen to them. So that's when the issue of resilience will take the bigger picture. So in defining resilience, it's a process. It's a process to harness resources to sustain overall well-being. So there are different kinds of resilience. There is the mental resilience, the emotional resilience, psychological resilience, economic resilience, political resilience, etc. So, but here for today's talk, I will just be focused on mental and psychosocial resilience, rather. So even the mental and the psychosocial resilience will be defined in various number of ways by different scholars. So, I just want you to understand that resilience, it's a process. It's not a state of being, or it's not something that is endowed. Okay, so it's a process. People will go through a certain X kind of experience, and they will develop some kind of maturity through that experience, and it will shape their brain and their behavior in a certain way, so that when they're faced with another issue sometime in the future, they'll be able to develop a healthy functioning. Bonanno also define resilience that it's a stable trajectory for healthy functioning after an adverse event. So the trajectory is characterized by a relatively brief period of disequilibrium, where the mind and the body will navigate to find equilibrium. Okay, so most people will have this ability to find and navigate this equilibrium, but some people will have the tendency to develop post-traumatic stress. So the other definition is a capacity of a dynamic system, to adapt successfully to disturbances that threaten the viability, function, and development of the system. So this is a much wider definition of resilience, which takes into account, different issues like the health system, the socio-political condition, the geographic condition, etc. But from my research, I like this definition of resilience, because it is kind of holistic. So in the context of exposure to significant adversity, resilience is the capacity of individuals or groups, to navigate their way to the psychological, social, cultural, and physical resources that sustain well-being, and their capacity in individual or at a group level to negotiate and to be able to to get these resources in a culturally meaningful manner. So I want you to emphasize on this culturally meaningful way, because when we are talking about resilience, as I said, it's an interplay. I will show you later on the factors, because it's an interplay between different factors, and one of that is culture. So we need to be culturally sensitive when we talk about people's resilience, because resources are different for different groups of people, because the resources or the issues that come into the context of resilience in Ethiopia and in Afghanistan, it's quite different. So we need to be culturally informed when we talk about resilience. All right. So here, resilience, it takes into account different aspects of health holistically, or well-being in general, because emotional health, mental health, social, spiritual, and physical health all make a person who they are or who they want to be in the future. And the experiences that people face in different sorts of states of their life, it can't touch all these categories of life: social, spiritual, physical, etc. And that in turn will lead to the person being being shaped into a certain type of character or resilience. So these are some of the determinants that that come into the interplay of somebody being resilient. So genetic factors, epigenetic factors, of course, DNA plays a role in some people being, really smart, really tough, and etc. When they are faced with different kinds of experiences. So one experience which is really difficult to process for somebody, it may not be as such difficult for the other person to process. That could be, that could be because of course, psychological makeup, their exposure, etc. But genetics also, and epigenetics also has an important role to play. And in terms of development, especially during infancy and childhood, children who are well cared for, who are being protected, or who have been raised in a highly protected environment, they could be resilient during the infant period and etc. But they may have issues when they grow up, when they leap into the adulthood, they could have issues. So development also plays a role. Demography is what I was trying to refer to earlier. People's place where they reside. Because when we talk about resilience, we are discussing about issues, that can hamper or that can hinder a person's well-being, and that could be, the natural, the nature, or for example, somebody living in a desert and somebody living, in a very in a good way, they don't have equal resilience, right? So because nature tends to shape our genetics and epigenetics. Culture is also another factor. I mentioned that earlier because, especially in terms of trauma, for example, in the Ethiopian context, in the Ethiopian culture, we have a very good place for the clergymen, for the priests, and etc. And in such cases where people are facing traumatic experiences, they tend to to dwell, or they tend to be attached to whatever the teaching of the church. So that, or the mosque, or any religious belief. So that culture will tend to shape the resilience nature of the society at large. Economic and social also, people living in a country where there is a better economy, better political system, etc., they are better able to be resilient whenever there is, natural disaster, a war, etc., rather than the people who are living in a disadvantaged society. So these are some of the determinant factors. So what are some of the factors that enhance resilience at an individual level. Most of the speakers before me, they have talked about this connection, cohesion, etc. So these are very important things that one needs to have, to be resilient whenever something bad happens in their life. So in connection, it means that people, if they have a meaningful relationship with their significant others, with their family and friends, it's a means of being resilient. And also engagement in different faith-based organizations, engagement at charity organizations or schools, etc. These are also some very important factors when faced with adversity in life. And in terms of communication, being able to share, explain and explore what has happened to them is really a very important skill. And also being able to reframe the adversity or whatever that has happened to them is a very important ability. And also having clear insights and also judgment about the scenario, the condition, helps the person to be more resilient. And also the third is confidence. It's a positive view of the self and a positive view for the world, and also having accurate sense of one's ability, and also believing that that individual can influence the outcome of the condition that they are facing through. The other is competency and commitment. So here is this is the ability to look at the big picture, to look past the trauma, past the life adversity, and also following through, also not giving up very easily of the commitment, and also working towards the achievement or the goal. So the other is also control. This is being able to manage strong feelings so that we can harness
Hello, we lost you probably. Dr. Ida?
enhance, we can become more productive and to develop coping, have a very...
Yeah, I think we lost you a while, maybe.
Okay, am I visible now?
You didn't share, the sharing is gone. So maybe you can share, but also we're running out of time. Maybe you can also speed a little bit.
All right. Okay, is it visible now?
Yeah.
Okay, all right. So I was just talking about competence, commitment, and control. These are very important tools for somebody to enhance resilience at an individual level. So at a community level, when we talk about community resilience, community is just a group of individuals. Resilient individuals will form a resilient community. So community resilience, is the sustainability of communities to withstand, adapt, and recover from any adversities of life. So what makes a community healthy and resilient is very important to remember that that community is socially connected, and they have, good access to health systems. They can act in a collaborative or collective way to mitigate any adversity. They're able to mobilize resources, and also the elders or whoever that's respected in the community, they're able to promote overall well-being. So these are some of the strategies to build a resilient community. We can strengthen and promote access to public healthcare and social services, promote health and wellness along the disaster preparedness, expand communication and collaboration. So engaging at-risk individuals and having, specially tailored program that can serve those individuals, and also building the social fabric or the social connectedness is very important. So this is something that I got from the Trauma Research Institute. So it's basically what I have already said, that to have a resilient community, all these things should come into an interplay. So source of resilience in the current Ethiopian context, for me, I would say that instilling a sense of hope, dignity, and coherence will be critically important for the Ethiopian community to foster resilience, in a country like ours, where it is, in the middle of a war, and also, there is a, rising social crisis. So the religious leaders and also the community elders, they play a very important or key role to promote social cohesion and also belongingness. So with this, I will end my talk, and I will just show you a brief video of I think this person. I have not, it's a public video. It's on YouTube, so that I'm using it. I'm using it also publicly. I'll try just to show you a very short video.
Continue.
All right, so maybe I will just share the video through email or another means. Currently, I'm not able to do any of what you're suggesting. So, so this is basically what I have for you for today. And I'll be glad to accept any comments, suggestions, and questions. Thank you.
Thank you so much. Sorry, there's somebody unmuted. Maybe you can mute. Thank you so much again, Dr. Ida. It's very, very powerful message in terms of resilience, and especially I really value you thought about culturally, informed approach. All textbooks may not, directly apply to our own conditions. So I think it's very powerful approach. So if there's any question, we can open for discussion. I saw one really important question in the chat. Probably in the West here, it's one issue, trauma, maybe some family issue or some other things, personal issue. But in the Ethiopian context, we have war, we have drought, we have famine, and we have all these different things. So how do you address all this in a multi-level approach? So maybe we can have that discussion starting with Professor Jonas.
All right, thank you. I think, Dr. Ida, I think it is very, very good that you brought up resilience, because sometimes we talk about trauma and then the resilience seems to be forgotten. And I think in the Ethiopian context, I also agree with you, the cultural factor is very important source of resilience. I think the video Dr. Ida was going to show us is a video message where Muslims and Christians were thanking Abuna Ermias. He was a leader of the church in a region called Waldia. So he refused to leave his people He risked his life. Basically, he could have been tortured or killed. He stayed there, and then he, regardless of the faith of a person, whether Muslims or Christians, he gave them shelter and support, spiritual and material to the extent possible. And that's really a huge source of resilience. And the other story I think she was going to share was, I think it's an audio or video of a father and son in a town called Shoarobit. They refused to abandon their city. They fought to the last, and a few minutes before his death, the father called his brother, who I think his brother is a physician. It's very powerful. And these types of stories, I think, are cultural factors that contribute to the resilience. I think she is sharing it on the chat so people can watch the video. To go back to the question raised by, a very good question was raised by Mazzino Bito, a very nice poetic name. So Mazzino Bito, he has asked, how do we provide mental health service, mental health counseling or service when a person, when the individual does not even have food to eat, has no shelter to live in. So basic necessities are lacking. So at least the Sudanese refugees, they were in a camp, they had a shelter, they were in a tent, they had food, they had water. So the basic necessities, without basic necessity, really it's very difficult to process any counseling or intervention. I completely agree with Dr. with Mazen Bito. The question is, how do we, are there these resources so that we always hear, it's honestly the last 2 years we have also faced the reality in the world. So United Nations and others, they will say, we will provide you or flood you with food, with shelter, with anything you want, just do what we tell you, this or that. And then when you meet whatever demands they put, they don't show up with the promise. So I think
Great. Dr. Taswai, what next?
Yeah, thank you very much again. So Dr. Mulugeta Simon, he has a guest who will speak for 5 minutes about, personal testimonial. Is Mulugeta there?
Hi, I'm here. Thank you everyone for attending and everyone who participated. The speakers were amazing, and hopefully we'll continue this. But one of the things that we've been stressing when we're talking about this meeting is really to try and find the problems from the sources meaning what do Ethiopians and what are the real problems in the ground. So we've been trying to find people to give us testimonies. Next time we'll have more. But today we have Dr. Nahom and Dr. Gannat from Alert Hospital. They both have experience with trauma, especially related to the war right now in Ethiopia. So I will invite Dr. Nahom to say a few things. Oh, before that, for those of you who don't know me, I live in New York. I'm a neuroscientist. I work at Columbia, and hopefully we'll meet again in other circumstances. But Dr. Nahom, feel free to tell us about what are the major problems in Ethiopia about mental health. Dr. Gannat was actually telling me earlier that the problem is really mental health is really frowned upon, and there's no organized solution for any of the problems. So go ahead, Dr. Nahom.
Okay, thank you, everyone. It's really a pleasure to join this session, and I can say I learned a lot in the last 1 hour. I wish I had this experience a year back. So to say about a few things about my job, I currently work at Ministry of Health, mainly coordinating the National Disaster Response team. So it's under the Emergency and Critical Care Directorate. So as you know, in the last 1 year, like significantly, and in the last 4 or 5 years also, we have been deploying individuals to different parts of the country to respond for disasters. So in the last 3-4 months also, I have first-hand experience. I've been deployed in the northern part, starting from Debre Birhan up to the Kobo area, joining the military medical team, and also in hospitals providing primary care. So I have witnessed there is a significant, I can say there's a significant need for psychosocial support, and the area is, as you can imagine, it needs support. So when I say this, it's not only about the patients. The healthcare professionals are also one of the they are also one of the victims, I can say. So there is one experience that really touched me, so I want to share that. If you guys, I believe only you know in detail the situations, what was happening in the last 6 months. So I remember there was one big hospital in the around Wello area. So they have been providing medical service for the military, for the casualties. There was an unimaginable number of load. The patient loss was significant. So they were treating, but finally, even that hospital became under security threat. So they were forced to be evacuated, and they were living, the professionals were also displaced, so they were living in Addis and in other safe places. So we were assigned, we were the first individuals to arrive to that hospital, and we were tasked to initiate the service immediately. So our main task was focusing on reinitiating the medical service in that area, and there was also active conflict in nearby. So there were active casualty victims coming to that hospital. So we expected the health professionals to get back to their working place immediately. So we, on the next, like after the city was liberated, in the next 3, 4, 5 days, we were expecting professionals to get back. So we see professionals coming to the compound, but they are not engaged in their activity. So the only active health professional working was the team from Addis and the military team. So we were like in doubt, what's going on, what's happening. So we tried to talk to them. So some of them were saying that they need this time to like they need time, so they are not ready to come back. So finally I start to communicate after 3-4 days. It start to cause attention in higher level also. So everyone is saying, why are not they coming back? So we are going to take measures. So we are going to write a letter. So finally, we start to communicate with health professionals one-to-one. Then we start to notice that they are also, we can say they are also a victim, like they are a patient, they have a traumatic experience related to their facility. Their evacuation was not safe. They were part of the community. So they spent 2-3 months as a displaced, as a regular citizen out of their working place. So we start to think, so besides taking administrative measures or discussion, so we may need some kind of debriefing at different levels. So we start to do that. Then we have seen some improvements, like just having a discussion, even if we don't have any background on like doing psychosocial supports, but it was really helpful. So that was the moment I start to notice, saying, oh, okay, so it's not only the community. Usually we neglect the healthcare professionals. We think they know about how to treat themselves, but that's not the reality on ground. So that's one of the aspects. The other thing is, as you know, following the conflict, we have the military active young individuals becoming disabled, with sustaining disabilities, living in different rehabilitation centers. So we have been receiving reports that now they are experiencing some PTSD-like symptoms. So there's also a gap in that area. This gender-based violence rate, as the media was also indicated, that there are unimaginable number of victims. So those also needs an attention. So as a primary working as a disaster response team coordinator, I have noticed like lots of gaps in areas where the professionals lack knowledge how to identify the problem in the community, even identifying it's a psychosocial problem to be treated even in themselves. So that's what I want to say. So we are working to strengthen the system, the responding individuals to have the knowledge and how to respond. So we look forward to work with you guys. Where previously it was known as Disaster Medical Assistant Team, DMAT. It was established 4 years back. Currently, we are working with other organizations like WHO on strengthening this team, becoming self-sufficient and multidisciplinary and ready to respond on all aspects. So we look forward to work with you guys also. So that's what I want to say. Thank you very much for your time.
Thank you for that very, very clear explanation of what the ground problems are. Dr. Marsha, Dr. Tasfai, continue.
All right. Thank you so much, Dr. Naham. It's very, very powerful and, personal experience on this big issue we are facing.
I just pasted my email on the chat, so we need a lot of information from the local people, what the problems are. Dr. Jonas, Dr. Tasfai, Dr. Udana, and I, and others in the group are thinking about writing papers, really bringing the problems out. So we will do that. Please just keep contacting us. There's someone here in this group who I will invite for like 2-3 minutes to give us an insight again about the local problems. This will be Dr. Gannat Kafle. She is an emergency and critical care medicine specialist at Alert Center. She's also the emergency and ICU director. Dr. Gannat, tell us.
So before that, sorry, Mulugeta, before that, is there any discussion for Professor Jonas before we move to different directions? So is there anything anyone want to bring at this time? Or we'll have a chance to discuss after Dr. Aida talk. Okay, continue, Dr. Mulgeta.
Dr. Gannat, go ahead if you're ready.
Okay.
Good afternoon, everybody. Thank you for the nice introduction, Mulgeta. So, other layers, my name is Gannat. I'm an emergency physician.
Can you speak louder? Sound is not clear.
Okay, can you hear me now?
Much better, thank you.
Okay, thank you. Good afternoon, everybody. Thank you for the timely and nice presentations. They are timely indeed. As earlier, as Nahom mentioned, we have had repeated incidents concerning how mental health is affecting our physicians who've been deployed and have come back from conflict areas. And as a hospital, Alert Hospital is taking it a little bit seriously, I think. We've had different talks on the situation, and we're starting our rehabilitation, both psychosocial rehabilitation and also the physical rehabilitation. But I just wanted to say a little bit about the AMT initiative. Previously, when we were deploying our team, the team is given all the necessary equipments needed to treat the physical traumas that they could find in the conflict areas. But the psychosocial component was completely overlooked, and many of them go to the areas and they come back. They're not that equipped to treat any psychosocial traumas they find there or they incur in the in the conflict areas. And currently, the MT team, or the Emergency Medical Team Initiative, which is the MOH initiative, is as the name indicates, an emergency medical team that is preparing itself pre-disaster, during disaster, and post-disaster, and is also giving both the treatment and the psychosocial support as we talk. Currently, we are on the አሁን ያለንበት ሁኔታ ያው ዶክመንት ፕሬፕ እና ትሬኒንግ ማኑዋል ፕሬፕ ማድረጉ ላይ ነው እና as Dr. Nahom earlier mentioned ብዙ ቦታዎች ላይ we need expert opinion እና expert help የምንልባቸው ኤሪያዎች አሉ starting from እነዚህ ስትራክቸር ማድረጉ ሆት ኮልድ ዲብሪፍ እንዴት እንሰጣለን ስፔሻሊ የኛ ፎከስ የሆነው ደግሞ የፊዚሻን ኮምፖነንቱ ላይ ነው like our physicians are not trained to cope with even emotionaቸውን ኔም ማድረግ አይችሉም like አይደለም ትራውማ አለ ብሎ ዊትነስ አድርጎ እንትን ብሎ ለመናገር ይቅርና they don't even know what emotions they're feeling እና በጣም ፎከስ አድርገን ፊዚሻን ላይ መስራት እንፈልጋለን እና ቴንክ ዩ በጣም አሪፍ ዲስከሽን ነበር እና ታይምሊ ነው it's well needed and I just wanted to say that. Thank you very much.
Myself, thank you so much, Dr. Gannat. Thank you for your service. I think this is, as you said, it's a very good discussion, and obviously we have Professor Jonas and others to follow on this and discuss with you and others. So if there is no any, go ahead.
I agree really, Dr. Nahom and Dr. Gannat. They are on the ground doing the work, really. So we will be happy to be supportive and be part of their efforts, to help them implement the vision they have. I think the Alliance for Research, Innovation and Education, Professor Tesfaye and his colleagues' team, is very practical. It is really focused on science. So it's we stay away from politics. So I think we're really eager and willing to collaborate in the way you want us to. Thank you.
Very good. Thank you so much again, Professor Jonas, for the comments. I think if there's no further discussion on this, we move to our next speaker.